Holy Mother of God. Today is the day that I want to lose all nursing boundaries because this patient is, probably will continue to suffer so much, and nothing was really done for multiple days, which is no one's fault really. It's you have to try things out and it takes time, but in the meantime, while you're trying things out, the suffering continues. And then by the time I got there, I was probably the third or fourth nurse to get there in a few days. It's they're at their wits' end, and I'm just seeing all of that. Today's one of those really hard days, a day that I honestly will remember for the rest of my life. I will remember this day, this patient, for the rest of my life. And it's hard because they were suffering so much, but it also is so amazing to be able to help someone and take the time to really try to help them. We have them comfortable for now. But I think they're going to have to be someone who's going to have to be medically sedated, palliatively sedated. Anyway, damn. I don't know what's been going on this week, but it's been tougher than normal. So that was a video I shot a few weeks ago after having a really, really rough couple weeks at work, really, because I was seeing the same symptoms over and over again, but with different patients. And I want to talk about those symptoms today because it's one I don't usually talk about, but it's very, very devastating. The symptom is intractable nausea and vomiting. Who does it happen to, and why does it happen? How do we help it? And why is it so devastating? This video is not meant to scare you, but I think it's really important as a hospice nurse who's educating online. I tell you the good, the bad, and the ugly of all the things I see. And intractable nausea and vomiting is one of the worst things I see as a hospice nurse. And basically what that means is someone is consistently and basically constantly nauseous or vomiting. So why does this happen? On hospice, it happens because of certain diseases, which I'll get into in a second. These diseases usually cause small bowel obstructions, which means there's an obstruction in your bowel so nothing can get through, so you're not really having bowel movements, and things are building up in your stomach. So anytime you eat or drink, or even just when your bile builds up, you will feel nauseous and you'll vomit non-stop. So how I see it typically as a hospice nurse is someone with colon cancer, stomach cancer, ovarian cancer, any kind of cancer that's in the abdomen and has tumors involved. Sometimes the tumors can block the small intestine and they can't operate, so it's just fully blocked. Or sometimes they will have a small bowel obstruction and they can't operate. So this is causing them to be constantly nauseous and vomiting. The other things that can cause this are something like gastritis or increased cranial pressure, but I see those less often. So what we typically do, this isn't something that has to be really devastating. There are things we can do to help with it, but a lot of times patients who are on hospice have already gone through those things so many times that they eventually are like, no, I'm done. The main thing we do is place a nasogastric tube or an NG tube, which is a thick tube, it's pretty hard, into someone's nose and down into their stomach. This seems like, what's the problem? That's not too bad, but it is. It is rough getting one of those placed. It can hurt and you can feel like you're gagging a little bit. It's just rough to get them placed, so people really, really hate getting them placed. But if we can, we'll place the NG tube, we'll put that tube onto suction and basically suction out and decompress their stomach. Now that will take away the nausea and vomiting. So people sometimes on hospice will just live with that tube, and it does fix the problem. However, it is very difficult to keep that tube in there, and it's very difficult for them to eat and drink. One, because they have a high risk to aspirate or to choke, and all of the food and water will get sucked out. If someone who's not on hospice gets a small bowel obstruction, that's typically what they do in the hospital. It's painful, so they'll go into the hospital, they'll get an NG tube placed, and they'll basically suction their stomach to give it a rest and to give their bowels a rest. And then the small bowel obstruction will just undo itself. Usually, that's usually what happens. And then in a few days they feel better, you take the NG tube out, no problem. We can do that for patients on hospice, and sometimes that works. Sometimes it works, the small bowel obstruction goes away and they feel better. But many times it's because of where a tumor is placed, and no matter what we do, it's going to be like that. So they'll have to live on that NG tube, or they'll get sick of that NG tube and say, no more, I don't want this placed anymore. And then we have to deal with the symptoms, which is nausea and vomiting. So that is what my video was talking about. I had a few weeks there where I kept running into patients that were having these issues and were no longer wanting NG tubes. They were sick of the back and forth with the NG tube. It's painful to put in. They've been struggling for a long time. So now we had to try to just help with them feeling nauseous and vomiting basically consistently. And it is rough. Because talk about suffering, witnessing that is true suffering, and it's really, really hard. Those are the patients where we try a bunch of things to hopefully help with that, but at the end of the day, it might help with the nausea, but it won't help with the vomiting because they're vomiting because nothing can go through their intestines. So what do we do? These are the patients that I will consistently advocate to be palliatively sedated, which means we give them medicine to put them to sleep until they die. Now, let me be clear, because there's a fine line between palliatively sedating and ending someone's life. We are not ending someone's life. What we are doing is keeping them comfortable until they die. And many patients will opt for this because they are suffering. Now, before we get to the whole palliatively sedated thing, we have to try a bunch of things to try to manage their symptoms. But at the end of the day, if we cannot do that, and this patient's on hospice and they continue to suffer, we will, and I will specifically as a hospice nurse, advocate for this patient to be palliatively sedated. Because if that's what it takes to get them comfortable so they can have a peaceful death, that's what we're going to do. Some things we can do before we get to the extreme of palliatively sedating someone that I think are really effective are suppositories. Medications can be given through the rectum via suppositories. So there's compazine suppositories that helps with nausea and vomiting. You can give liquid morphine, which is called Roxanol, or liquid Ativan, which is like a relaxing medication through the rectum, and that can be really effective. So if the patient's willing to get rectal medicine, I always go for that first, and a lot of times that can help with their symptoms. Another great alternative would be something called the Macy catheter, which is basically a catheter that is placed in the rectum, and then the catheter comes out and is usually placed on the patient's thigh. This is where, once it's placed, the patient can give themselves medication, or the family can give medication to the patient, and that medication goes into the rectum. And again, like I always say, the rectum is very vascular, so that medication is absorbed in the rectum and should make them feel better within 15 minutes or so. Whenever I see patients like this, for instance, in my video I just showed you earlier, I usually start with the rectal medications, and those can be effective for some time. So if we can do that, we always start with the suppositories or medications in the rectum, and then eventually, if those stop working, that's when we can step it into palliative sedation, if, of course, the patient and family are okay with that. This also could be a time when someone gets a CAD pump, which is when there is either IV medication if they have like a central line or a port that can be accessed, or you can do sub-Q medication, hook it to a pump, and medication can be delivered through subcutaneous tissue or through a central line, which goes right into the bloodstream. That would usually be a way that we would manage it if they are being palliatively sedated, which really just means that is a way we could palliatively sedate somebody, or a way we could just give them enough medication that they do feel better. At the end of the day, they are nauseous and vomiting because of an actual thing that's going wrong in their body. You know, their stomach is making stomach acid like it normally does. They have to drink and eat because they're still awake and they're sometimes thirsty, sometimes hungry. So they're still taking things in. And no matter what kind of medication we give, they will throw up because that stuff cannot go anywhere because they have a small bowel obstruction. Right? It doesn't matter how much medication we give sometimes, they will still have those symptoms because there's something physically going on in the body. Hence why it can be so hard to manage these symptoms. So we can kind of get them relaxed, kind of get the nausea under control, but they will still continue to vomit no matter what we do because there's a physical obstruction in their body. And that is the main issue. So like I said before, this is one of the tougher parts of my job. And when I witness it while I'm working, beginning, it does make for a rough day for the patient, for the families, for the nurse who is witnessing it as well. But I like to make videos about it to educate about what we can do to help it. There are always options we can do, and we will escalate care until you are comfortable. So don't forget to advocate for yourself, talk to your healthcare providers, see what will work best for you.